There's a lot of misunderstanding among dentists about bisphosphonates and osteosurgery and implants. Because as we know, bisphosphonates can affect the bone, which can affect healing, implant placement, and extractions of teeth. So let's clear all that up right now. After this video, you're going to have a clear understanding of how to work with patients who have been taking bisphosphonates. This lady had had a single bisphosphonate injection in September of 2017, and she had some restorative work to be done, including some teeth extractions and some implant placement. So we waited 6 months. You can see she's got some broken down teeth here. We're going to place 2 implants and then place another crown on the molar tooth. Just some unsightly old restorative work. This is the area right here. We're taking out this tooth and this root tip, placing 2 implants and then placing another crown on the first molar. But before we do that, we need to deal with the bisphosphonates because it can cause osteonecrosis. Let's read this. This is a very excellent article on bisphosphonates, and this is in the article section of DentistryMasterClasses.com. We put many pertinent articles in that section so you can read them if you subscribe to DentistryMasterClasses.com. Let's read this. Recent data on the value of the CTX test as predictive of osteonecrosis of the jawbone in patients exposed to bisphosphonates. This is the issue with patients taking either oral or injectable bisphosphonates. If you extract a tooth or you place an implant in these patients while the CTX level is low, there can be a problem with osteonecrosis of the jaw. CTX blood levels can be used as an indicator of bone breakdown resorption. In patients with increased bone turnover, the CTX levels are high. When bone turnover is decreased by a bisphosphonate, that's what a bisphosphonate does. It decreases the natural bone turnover in patients. The CTX levels are low. So low is bad, high is good. It's claimed that these effects can be seen within weeks of beginning bisphosphonate therapy. The use of the CTX test as an indicator of the risk of osteonecrosis of the jaw was first suggested by Marks in his textbook on osteonecrosis of the jawbone, Quintessence 2007. He reported that serum CTX levels, less than 100 pg per milliliter represent a high risk of osteonecrosis of the jaw. 100 to 150, a moderate risk, and greater than 150, minimal or no risk. So we want CTX levels greater than 150 before we extract a tooth or place an implant. We want CTX levels greater than 150 before we extract a tooth or place an implant. In other words, before we do anything with the jaw bones. For example, Marks reported mean CTX levels of 73 pg per ml in a sample of 17 subjects with osteonecrosis of the jaw after exposure to oral bisphosphonates. So they had a low level, 73, not near 150, and they contracted osteonecrosis of the jaw. They also reported an increase in CTX levels of about 26 pg per ml per month after discontinuation of the oral bisphosphonate measured over a 6-month period. So the CTX level should rise about 25 pg per ml every month the patient is off the bisphosphonate. Now I'm going to show you a case that didn't happen and what we did about it. So this lady had had a single injection of bisphosphonate in September of 2017. We waited and we measured her CTX level and she had a level of 81 almost 6 months later. So that's October, November, December, January, February, March. That's 6 months later, It should have gone up 25, reading 25 a month, and it didn't go up at all over that period of time. And we thought, what's the problem? So we sent her to an endocrinologist here in town who also happens to be a patient of mine. And what she found was, it was noted the patient is taking large amounts of vitamin D, which may cause changes in the patient's C-peptide level. In other words, large amounts of vitamin D can affect the CTX reading and keep it from going up. And that was the case with this lady. So she took her off of the vitamin D right after that in March of 2018. By June of 2018, her level was up to 198. The CTX level was 198. So it just rocketed up once she got off the large amounts of vitamin D. So the takeaway from this is, you want to test the patient's blood for CTX levels if they've been taking bisphosphonates. And you can do this, or you can have an endocrinologist do this. The level, the CTX level should be over 150 before you extract a tooth or before you place an implant. It should go up 25 points every month they're not taking the bisphosphonate. If it doesn't go up that much, be sure they're not taking vitamin D. As a matter of fact, from the get-go, be sure you tell the patient, don't take vitamin D, because that can keep the CTX level from going up as it did in this patient. So at 198, we're good to go with extracting the tooth and can be very confident to place the implants, which we've done, as we'll show here. Here are the implants placed, the teeth extracted. This is the final implant restoration and the crown on this tooth and a crown on this tooth, the cuspid. So 2 implant crowns here. So this is what you need to know about bisphosphonates. That's the Dental Minute. These methods work, and they work every time.